Hi, Shaheenah. I'm Goal. How's everyone?
Very well, thank you. Thank you.
We're good, thanks.
Nice to see everybody. Got home safely post ASCO.
So good morning, good evening, and good night to everyone from across the globe that's joining us for this edition of the EIOC Journal Club. My name is Shaheenah Dawood, and I'm a consultant medical oncologist coming to you all the way from the United Arab Emirates. Today, we'll be talking about some post-ASCO updates, specifically focusing on patients with hormone receptor positive disease, looking at the integrated use of CDK4/6 inhibitors. I'm joined today by some spectacular local, regional, as well as international faculty, and I'm going to allow them to introduce themselves. Stephen.
Hi, everyone. Stephen Chia, medical oncologist at the BC Cancer, Vancouver.
Bassel, is he here? Has he joined?
Yes. Good
Bassel, I
evening
can't see you.
from Abu Dhabi. Can you see me now?
Yes, I can.
All right, brilliant. Bassel Jallad from Cleveland Clinic in Abu Dhabi.
Dalia.
Dalia ElShorbagy, SSMC Abu Dhabi.
Hassan.
Yes, good evening. Hassan Ghazal at Al Zahra Hospital in Dubai.
And Maroun, my partner in crime, right down the road from me.
Maroun, consultant oncologist at American Hospital in Dubai.
Thank you. Can you please put the agenda up? Can the index team? Yes. So we're going to start off with Stephen actually giving us the updates from ASCO. And then after that, we're going to go into a very interesting panel discussion. So Stephen, take it away.
Thank you. Can I take over? I have to.
Yeah, you should be able to share your
Okay.
slides.
Okay. So just confirm that
Can see it.
can
We
see my
it.
slides.
Yes.
Okay.
Yes.
So thank you, Sheena, and thank you everyone for taking your time out of your evening. And I'm not going to go extensively through like 10 or 12 abstracts, because I feel like there was a lot at ASCO. What I wanted to focus in was 3 specific studies focusing on the issue of de-escalating treatment, because I think, as we heard from ASCO, there are a lot of studies about adding more and more and more, but there's also some work about optimizing treatment or de-escalating, and then a study on a search for biomarkers regarding adjuvant CDK4/6 inhibitors. These are my disclosures to myself or my institution. So I know there was a little bit of conversation before we started here about the Optima trial, but I think it's definitely worth reviewing because many of us are used to using genomic assays, but not necessarily the one utilized in this trial. So as a reminder, this was an academic-led trial through the UK with participation also in Norway, Australia, and New Zealand. The majority of the patients came from the UK. They included women and men, but women premenopausal had to be 40 years or older. So the data does not include and should not be extrapolated, in my view, for under 40. ER had to be at least 10% to qualify. The number of nodes was up until 9 positive nodes, so N2 was included, no preoperative chemotherapy. What's slightly unique about this trial design is that they wanted to call it test the test. So basically, patients were randomized to get standard of care. So clinicians enrolled patients that they thought would standardly get chemoendocrine therapy. And if they got randomized to that arm, got their chemotherapy followed by endocrine therapy, but had the genomic assay at the back end for the analysis purposes, versus randomized to the genomic assay, the Prosigna up front. So this we'll talk about a little bit later. It's a 50 gene assay. It could be done in your actually local pathology lab if you have enough infrastructure volume. And if you were randomized to the test up front, if the ROR score was 60 or less, recommendations not to get chemo, but endocrine therapy versus greater than 60 chemoendocrine. The other very, I think, important issue about this study that I congratulate the authors on, that we did not do so well in the North American trials of Taylor RX and RX Binder, is that premenopausal women were required to get ovarian suppression as part of their optimal endocrine therapy. The study design was meant to be a non-inferiority to demonstrate that not giving chemo with randomization both to the tests, but also the group of patients that did not get chemo in the under 60 or under ROR score, with the margin being 3%, which I think is a reasonable margin where most patients would not do chemo for a 3% or less benefit. This supports both a clinical utility and a what's called a health economic analysis. The endpoint was invasive breast cancer-free survival. So this is our traditional endpoint, but excludes a non-breast cancer primary, which I think is reasonable when you're looking at non-inferiority studies about adjuvant chemotherapy. So the other thing this study was that the adherence to the randomization was excellent. So 4,429 patients, one-to-one randomization. At the end of the day, you can see here various reasons why there were test failures were actually not that common. But at the end of the day, 93% included the per protocol treatment in both arms. And within that, virtually everybody on the chemo control arm got chemo. Only one patient did not get chemo, which I think is the adherence is phenomenal there. And in the test-directed arm, you can see here about only 1/3 got chemo based on the test results, and 2/3 did not get chemo. They were spared because the ROR score was 60 or less, so they got endocrine therapy. And the other here, 13, is a pretty small number in terms of non-adherence to randomization. The types of patients enrolled, to keep in mind, about 40% or so, or 37% were premenopausal, 1% were male. A third were grade 3. So there was a lot of grade 1 or 2s, and I think there was, a consideration because of the sort of the test assay to de-escalate chemo. There was exclusion of, a high proportion of grade 3s. If the case was no negative, they had to have a sufficiently large tumor. So most, in fact, were no positive, but most were actually N1, 1 to 3 nodes, and 19% were 4 to 9 nodes. And we could talk about whether that is a reasonably large enough sample size for confidence or not. So when you look at the test-directed arm, again, with the inclusion of the study population, 2/3 had an RO score less than 60, and in the test-directed arm were basically did not get chemotherapy, got optimal endocrine therapy, again, ovarian suppression for premenopausal women. And a similar distribution in the control arm where the assay was done on the back end. So this study met its endpoint of non-inferiority, both for the entire per population randomization, but also in the ROR 60 or less subpopulation in both arms. Remember, in the control arm, virtually everybody got chemotherapy. In the test-directed arm, virtually nobody got chemotherapy. The actual difference was about 2% or 1.2% difference. It met the non-inferiority margin. In fact, a 2% limit was the margin. So I think this, again, does give good confidence. And then you got roughly about 2,500 patients in the less than 60 ROR and about, again, 4,000 some patients in the entire to treat population. If you look at the endpoint of distance recurrence-free survival, very similar. 1% difference met non-inferiority, 1% difference in favor of chemo, but again, met non-inferiority. The other thing to note is that, with an ROR score less than 60, the prognosis is excellent. So at 5 years, the distance relapse-free interval was 96 and 97%. Still early because the ROR score less than 60 generally capitulates the luminal A subgroup. And I think, though there's no benefit to chemo, their risk of a late recurrence is going to be not insignificant, perhaps. If you look at the various subgroups overall, there was consistency of results. Nothing really, I think, stands out. The relatively smaller group of grade 3 with wider confidence intervals, it did favor the other side of 1, so I'm not sure you can make anything out of any subgroup here. If you look at the premenopausal versus postmenopausal, and again, premenopausal is of interest because of lack of clinical utility for premenopausal node positive, and also for those who are node negative with a score of 21 or higher, we would consider chemotherapy here. Premenopausal hazard ratio 1.04, and a 1.3% observed 5-year difference in favor of chemo. Similar results in the postmenopausal group. And then in the 1 to 3 lymph nodes, which was again 75% of the population, hazard ratio 1.11, 1.6% difference. In the 4 to 9 lymph nodes, here hazard ratio 1.19. Just visually, you look at the curves in the 1 to 3 nodes, the curves sit on top of each other. Even in the premenopausal, postmenopausal, go back. I think, again, this is my bias here. The 4 to 9 lymph nodes involved, the curves do look visually separate after 3 years. I'm not saying there's a difference there, but I feel here the confidence intervals for the hazard ratios are still pretty wide. And I think, in my view, further data is required, I think, in the N2 population, particularly perhaps in the premenopausal group. The author did a good job to highlight a few of the limitations. This was still an earlier analysis. The median follow-up is a little over 3 years. All patients had a 1-year follow-up at least, and 63% had 5 years of follow-up. It's probably true most chemotherapy benefit you would see in the first 5 years. So I think we do want to, see a little bit more mature follow-up, but we got a pretty good glimpse at this point. As in many trials done in Western Europe, most of the population were white. As stated, the data does not include premenopausal under 40, and cost-effective analysis is ongoing. So this was the author's conclusion. I would agree the Optima demonstrated the 50-gene prosigna identifies a group with minimal, if any, benefit to chemo. I think it has demonstrated non-inferiority for women premenopausal over 40 treated with ovarian suppression. I'm not sure I completely agree that patients with 4 to 9 lymph nodes, we can use this data to safely avoid chemotherapy or not deliver chemotherapy. It was not powered in this subgroup. Now, we do have a future trial that just opened in North America, in the US. It's led by the ECOG Akron group called the RX-FINE. So this will, I think, further answer the question in the 4 to 9 lymph nodes. It is looking at postmenopausal women, stage 2 that are T3N0, not included TAILOR-RX, 3 out of 3 positive lymph nodes without an axillary node dissection, or your N2 population. If the oncotype is 0 to 25, they're randomized to chemotherapy followed by endocrine and ribociclib versus endocrine and ribociclib as a non-inferiority trial. Also, invasive breast cancer-free survival is their primary endpoint. Excuse me. So I think this will take a number of years to accrue and read out, but we will have further data to safely avoid chemotherapy in our N2 population. I'll then quickly move to see if we can find a predictive biomarker in adjuvant CDK4/6 inhibitors. This group knows well the Natalie trial. I will highlight here, I think we all know it did include stage 2A, so T2N0s that required an additional factor like grade 2 in high Ki-67 or genomic score, or grade 3. And one disease, as long as macrometastases, could be any grade. And then again, all stage 2Bs and 3s. 3 years of ribociclib versus not, but the endocrine therapy was optimal, meaning premenopausal required ovarian suppression, and all patients required an aromatase inhibitor. We used the 5-year cutoff, pre-specified 5-year analysis cutoff that's been presented last year at ESMO by Dr. Crown and published in ESMO Open thereafter. And this is an exploratory endpoint for gene expression. We used the NanoString Breast Cancer 360 panel. We're able to successfully retrieve 3,022 patient samples out of the 5,101. So that's 60%. Now, remember, 88% of patients on the study received chemotherapy, either pre-op and post-op, and about half were pre-op, half were post-op. So in the majority of the samples will have had chemo, of which half of them, this is the resected specimen post neoadjuvant chemo. So this is the residual disease specimen. The NanoString BC360 does give you the PAM50 subtypes that we'll talk about. It also looks at breast proliferation signature and immune signature, among others. We did look at both prognosis and prediction, utilizing a Cox proportional hazard ratio with the stratification factors required on the study. Now, all of the data I'm presenting, the p-values are nominal, two-sided without correction for multiple analysis, and we also acknowledge that there will be a false discovery rate. When I talk about the volcano plot, I'll describe how we looked at the treatment interaction based on the quantification of the hazard ratio with the expression by interquartile range of the biomarker. So first thing, the 60% biomarker population is representative of the ITT. You can see here in terms of hazard ratios, they're pretty similar at 0.72, 0.71, and the difference in event rates was 4.4% in the biomarker population. So the curves look similar. So I think it's generally representative of the ITT population. When we did the PAM50 intrinsic subtype, you can see that the majority, 2/3, were luminal A, 20% luminal B, and a small percentage HER2-enriched and basal. In the node negative, by requirements of the grade or a proliferation marker for the grade 2, T2 and zeros, there was a higher proportion of luminal Bs in the node negative versus the node positive, and that would be expected. And that's a slightly lower rate of luminal A's and a slightly numerical higher rate of basal-like. Likewise, in stage 3, slightly more luminal A's relative to luminal B's compared to stage 2s. So two things. Prognostically, the subtypes do show what has previously been demonstrated, that luminal A's have the best prognosis. So you look at the control arm for luminal A, 84.7%. In the control arm for luminal B, 80.8%, and then HER2 enriched and basal-like down to about 55%. So there is a strong prognostic effect for subtypes. The subtype, however, does not predict for magnitude of benefit from ribociclib, but at least significant magnitude of difference. So luminal A's had a hazard ratio of 0.77, luminal B's at 0.71, HER2 enriched 0.5, and basal's 0.42. Now, the HER2 enriched and basals, the sample size are small, again, 3%. Confidence intervals are relatively wide, and we can have a later discussion about this. But I do think that basal-likes are likely going to be your ER low population. When we did the interaction test, none of the subtypes were shown to be predictive of a significant difference in ribociclib benefit. So basically saying one should not take intrinsic subtype as a way to, I think, deny a patient the opportunity to consider adjuvant ribociclib. Again, multiple signatures are seen from the BC 360 panel. One of them is a genomic risk signature score, kind of recapitulates the ROR score. They're going to be higher in luminal B, HER2 enriched and basal versus luminal A. Likewise, proliferation signatures, they're a step up from luminal A to luminal B in proliferation, and more so even for HER2 enriched and basal. You can see by the way we split up the signature scores into tertiles that the highest tertile for both gene risk signature and proliferation signature seem to have a greater benefit. But again, this was not significant on interaction test. This is called the volcano plot. So for every gene, 756 genes on the actual 360 panel, we plotted this as a Cox proportional hazard ratio with the stratification factors. On the x-axis is the hazard ratio either increasing to the right based on the interquartile range increase of the expression of that gene. And then on the y-axis is the significance by likelihood ratio test. And so those that are above the dotted line that goes from left to right is potentially predictive. And then on the left, you can see here of 1, that means a higher expression is associated with a greater ribal benefit. So for example, CEA CAM6, you can see on the x-axis, normalized higher expression, a better hazard ratio, less than 1, versus something like a GATA3, which, as you know, is a product of the ER alpha signaling, lower GATA3 expression, increased ribal benefit. And again, you can see here going towards the left, the lower expression, the better the hazard ratio. A couple things of interest. We know from the monarchy correlative analysis that looked at the DNA analysis. So this is c-Myc amplification, so high copy number ratio. There seemed to be a trend for lower abema benefit. So when we specifically looked at MYC expression, so this is RNA, not DNA, we saw a similar trend, high MYC expression, lower ribal benefit, but that was not statistically significant. And I think one other thing of interest is that you can see here on the right side, CDK4 may be predictive of higher expression of CDK4, lower ribal benefit. Again, that's something it's exploratory, not validated, but we do know there are CDK4/6 inhibitors in development, and they are likely going to go into adjuvant trials, and that might be something to look at as a biomarker within those studies. Another way to show this is, again, CEA-CAM6 is a biomarker overexpressed in a proportion of breast cancers. It's associated with increased proliferation, endocrine resistance, and worse survival. You can see here a high expression, and it's also upstream of CDK4/6. CEA-CAM6, higher expression, seems to be associated with greater benefit. But even on the low expression, there was some benefit to the ribose. So it's not something I think that is clinically validated. And likewise for GATA3, again, higher GATA3 means probably high ER alpha signaling that can be better shut down with endocrine suppression with aromatase inhibitors. So higher expression, there was less differential benefit with standard endocrine therapy versus the lower benefit there was. But even in the middle, there was still some benefit to the ribociclib. So in conclusions with this analysis, this is the largest collection of resected samples to do a correlative analysis on an adjuvant CDK4/6 inhibitor. I think we're able to show that the ribociclib benefit was consistent across the biological subtypes. There might be a trend for higher genomic risk and proliferation signatures, but it was not statistically significant for interaction tests. There were several genes that might be associated with differential benefit. Again, these are not validated. And I think all of this still supports that patients that were eligible for the NATALEE trial should be the selection criteria for consideration of ribociclib. I'm going to end with, I think, a presentation that is immediately practice-changing that I will be talking to patients, including one in my clinic I'm going to go see in the next half an hour to potentially de-escalate her bisphosphonate or her actually bone-modifying agent. So this was a Swiss-led study, actually funded by the Swiss government, looking at preventing symptomatic skeletal-related events with less frequent use of denosumab as a phase 3 non-inferiority study called the REDUCE study. So this took both metastatic breast cancer patients and metastatic castrate-resistant prostate cancer patients with bony mets. They had to have, you'll see, 3 or more bony mets. About 1,400 patients. All patients received the standard induction phase of 120 milligrams sub-Q every 28 days for 4 cycles. And they were randomized then to get it the standard right now, which is every 4 weeks, or was the standard every 4 weeks, or giving it every 12 weeks. The primary endpoint was time to first skeletal-related or symptomatic skeletal-related events and other secondary endpoints, including overall survival. Again, inclusion criteria we talked about. Patients had to have 3 or more bone lesions, lytic, blastic, or mixed, documented within 12 weeks of enrollment. And patients had to have current or planned anti-neoplastic therapy. So this may not apply to patients that are not doing conventional treatment, are really looking at other sort of complementary treatments. No prior denosumab or bisphosphonates were allowed. So this is a non-inferiority study. Their non-inferiority margin that they planned was 1.20. I'm a little bit unclear if that was based on the hazard ratio itself or the hazard ratio margin not to hit 1.2 in terms of the confidence intervals. It actually doesn't matter because their margin did not cross by confidence interval 1.2, so they met that strict definition if that's what they intended. So what type of patients were enrolled? About 55% were breast cancer, the rest were prostate cancer. Again, 42% had 3 to 10 lesions, but there was a significant amount, 57% or greater, that had more than 10 lesions. Probably many of these were prostate cancer patients. This study, I want to highlight a few things, met the non-inferiority margin. So the median follow-up was 37 months. And you can see the denosumab is actually slightly higher on the curve than the every 12 weeks than every 4 weeks. The margin is hazard ratio 1.023, and the 90% confidence intervals do not cross 1.2. So I think it did meet its non-inferiority. The other thing is the time to first on-trial symptomatic skeletal event was long at 56 months. So this is almost 5 years for patients to get on to have their first symptomatic skeletal event. Again, I think that highlights the effectiveness of our systemic treatment we have both for prostate cancer and metastatic breast cancer today. And you can see the breakdown. Most of the events were radiation to the bone. Fortunately, few surgery and spinal cord compression events. Even the secondary endpoint of time to first and subsequent SSE met the non-inferiority, did not cross the 90% confidence interval 1.2. There was less hypocalcemia, mainly grade 2, less grade 2 on the every 12 weeks, and also less grade 1s. And also the time to either tooth infection or ONJ seemed to trend to be less for the less frequent denosumab, which makes sense. Overall survival as a secondary endpoint here was also appeared to be non-inferiority. The confidence intervals do not cross 1.2, meaning overall survival, some in the range about 40-some months. So not surprisingly, there's going to be savings to the patient. So the direct consumer costs patients did pay for their medication in Switzerland was about 55% cost savings. And the estimate to the Swiss healthcare system was about 15 million alone on the drug. So I tried to calculate the savings to patients because, again, this is also not covered in Canada. Patients pay out of pocket. I estimated that's about 13,000 Canadian dollars. So as you know, I work and live in Vancouver. We're one of the host cities for the World Cup. Next week, Canada plays Switzerland next Wednesday. The tickets in the lower bowl is about 3,500. So for a patient, if they went to every 12 weeks, they would save $13,000. They could buy 2 tickets to the World Cup game and actually have a few $1,000s extra to buy beer. So the conclusions were that Q12 weekly denosumab was non-inferior to Q4 for first symptomatic skeletal-related event. It was a better safety profile, the reduced drug costs, and I agree with the authors. It can be the new standard of care for patients that have 3 or more bone mets that are on systemic treatment for their breast or castrate-resistant prostate cancer. So my last slide overall is that the optimal trial, if you're interested in using the Prosigna, does provide an opportunity to de-escalate adjuvant chemotherapy, particularly in a group of patients where a genomic assay like Oncotype does not have clinical utility, that is premenopausal with N1. I think in part why this study was successful to demonstrate that was that they required premenopausal to get optimal endocrine therapy with ovarian suppression. Now, the Prosigna assay requires a specific machine, requires the reagent kits to do it, requires, I think, upkeep, optimal volume, and pathology support. So your local pathology needs to identify and macro dissect the invasive tumor. So if you are interested, though I don't know how it will work in other parts of the world, you will require infrastructure support, pathology support, sufficient volume to do in-house testing. But it does provide an opportunity for our premenopausal N1 patients. I don't think the N2s, I think we need further data to truly avoid that. Maybe in your 4 alone, so 4 involved lymph nodes, but maybe not your 9 involved lymph nodes. We don't have a validated predictive marker to exclude patients from considering an adjuvant CDK4/6. I think ctDNA that people are very interested in, it will be prognostic, but not predictive. So Will it be the ones that have no detectable ctDNA? Will be the ones with ultrasensitive assay? Perhaps you might not consider it. I don't know. We'll have to see. We have two studies, one with bisphosphonates about less frequent after an induction phase. And now we have a study with denosumab. And I think that less frequent bone modifying agents should be the standard of care today. And actually think in those patients that are on a systemic treatment for their breast cancer have been on denosumab for more than 4 cycles up front, I am going to de-escalate them to every 12 weeks now. So with that, I'm going to stop sharing and pass it back to our faculty for the next part of the program, and thank you.
Thank you, Stephen, for giving us a good overview of the important data that came out of ASCO. I have questions if nobody else has any questions, but
I have.
I have.
well, everybody has questions. Okay, so let me start because I get privileged
That's
since
okay.
I'm
You are the
of this
queen. Of
meeting.
course.
So, Stephen, I like the biomarker data that you showed for adjuvant CDK4/6 with ribociclib. Now, when you look at that slide where you've substratified based on luminal A, luminal B, and the Bassel-like and HER2 enriched, visually, now I know the numbers are small, this is, exploratory analysis. Visually, the biggest benefit seems to be in those patients with the really bad biology of disease. Am I right in actually interpreting that data? And in that luminal A and luminal B, which is the biggest bucket of patients that you have, probably the benefit is more later on. But in that really bad biology, you're getting your biggest bang for your buck right up front, is what I'm trying to say.
Yeah, I think you're right that the non-luminal A's tend to have a stronger hazard ratio, with the caveat the HER2 enriched and Bassel-like are very small. I do think some of the luminal A's, like your N1 luminal A's, a single lymph node, their prognosis is probably quite good, and they're probably at more of a risk of a late recurrence than early. So I think there's probably some room to explore groups of patients further that you might think that the benefit is pretty modest, if minimal.
Yeah, I mean, the way maybe I can comment, Shaheenah. So the way I think about it, it's proportional benefit. So what it means, you may have similar hazard ratio, but since your recurrence rate is going to be higher anyway in those higher risk patients, you are going to see a more visible variance, if you want, or benefit in those who have a higher risk to recur early on, especially we have these follow-up early on. So it's going to be more apparent than, for example, the luminal A, as you
I agree, but
correctly pointed.
even one more question before we move on to the discussion section of this journal club. Were you surprised to see that there was a benefit in the Bassel-like and HER2 enriched? I actually thought that when you presented the data, we would not see a benefit. We would see a negative impact, actually. But were you surprised to see that there was a benefit?
I wasn't completely surprised, though I think the magnitude was a little bit more than I expected, because for Monarchy, again, when they looked at that, there was a trend all in favor, except maybe the Bassel-like not so much. I think the difference here is we're trying to dissect out, is the Bassel-like really just the ER lows, which they had to be ER positive to get in, or were these the ones that got neoadjuvant that had some residual disease still that were true triple negatives, but they should really benefit more from neoadjuvant? So it's still small, 3%, but you're right, it was more than what I expected. But there might be some explanation for that again. And we know some of the luminal Bs end up being more HER2 enriched by the way how the PAM50 algorithm segregates them more on the HER2 enriched, but they still are they're still ER positive.
Because the reason why I asked this question is that, we always have these horrible discussions in our MDT for these patients who are ER low, whether to treat them like triple negative or to treat them like hormone receptor positive. So what we tend to do is we do Keynote 522, treat them, but when they have residual disease or something like that, then the question is, should we start that CDK4/6 up front versus waiting the year, completing the pembro, and then starting it? I mean, what are your thoughts there?
So I have this exact case of this wife of a lawyer, true story. Wife of a lawyer, ER low, so treated her Keynote 522, had RCB3, so bad disease. She was PALB2 germline. So I threw everything at her, not because her husband's a lawyer, by the way, but I just did. So gave her the pembro, gave her cape, gave her olaparib, and now she's getting ribo after she's finished her olaparib.
So my question is, you gave her olaparib, so you gave her pembro, olaparib, and cape?
I gave her pembro cape first, finished the cape,
in sequence,
and then gave her the olaparib after the cape, but she had basically already finished the pembro. So it was monotherapy olaparib after the pembro cape. And then we talked about, I was uncertain about the ribo. I said, you know, we don't really know if the benefit will be there. This analysis, I don't know, suggests that there might be. She was like wanting to do everything under the sun. They could pay for it. So, you know, I relented at the end.
Okay. I mean,
Just if I can, one comment on the bisphosphonate and denosumab, because I was involved. I was a PI, and I remember in USA when I was there with, I think Gabe Hortobagi was the PI on the same topic using this bisphosphonate. So this is a decade ago. We proved that every 3 months is non-inferior to monthly, but I think this is with denosumab. So it's really mirroring what we showed back in the bisphosphonate era.
Yeah.
Thank you for letting us know, Dr. Hassan. So let's now jump right into the case studies.
Can I ask a question about Optima?
Sure, go ahead, Maroun.
Yes, please. So, Dr. Chia, I mean, I look at Optima as the Prosigna as a to complement the Oncotype DX. For example, I think if you have a 42-year-old patient with 3 positive lymph nodes and with an ROR of 50, I think long-term follow-up is not enough to make me feel that she does not need chemotherapy. So how we look at it is that if her Oncotype DX, for example, is 15, 16, 17, 18, you can complement it by an ROR less than 60 to make a decision. But I don't think it's ready for prime time practice in these young population with node positive disease. What do you think?
Yeah, I think I think it is a smaller segregation. Remember, 37% were premenopausal, and then 75% were 1 to 3 lymph nodes. So you're cutting it into smaller subgroup there. They've done a direct comparison, not they. So there was a poster at San Antonio from the TransATAC where they looked at the concordance or discordance between the Oncotype and the Prosigna, and there's actually a lot of discordance, 45%. It seems like the ROR less than 60 is the strongest prognostic factor rather than the Oncotype. So, I think it is some interpretation if you feel, whether it's strong enough to deny a woman chemotherapy. There's ongoing studies called the Offset in the US that would try to answer this question as well. I think we have some benefit, obviously, from the adjuvant CDK4/6s, so I think that provides some confidence. And that was not part of the study design here in Optima because it was enrolled quite a few years ago. So it's a long-winded answer that in some patients that are really keen to not do chemo and they have a ROR less than 60, 1 to 3 lymph nodes, they're going to do LHRH-AI and a CDK4/6. I might actually not give them chemo.
But Stephen, I think one of the problems that I have with Optima is the fact that they haven't published it yet and haven't shown the granularity of the data.
Great.
So I'm extremely uncomfortable, implementing it into clinical practice now without having that data. And
agree with that point.
35% premenopausal, and we don't even know how many of them actually had the number of lymph nodes that people are discussing. But Hassan, thank you. I know you want to ask a question.
No
question.
Just comment on the Oncotype.
We have to go into the cases.
We cannot use Oncotype in node positive premenopausal. According to our exponder, regardless, they had benefit. I know
that is a topic of another. That's a topic.
I know. Because Maroun was mentioning Oncotype.
Come on, sometimes you have a patient that insists on Oncotype with 1 positive lymph node, and you get an Oncotype of 14 or 12, and you
Yeah,
try
but
to struggle what to do with it. So we
I
have
the
would
those
data.
really
patients.
like to continue
Okay,
this
go
discussion,
ahead.
but we do have only 20 minutes. I'd really
Yeah,
like
go
the
ahead.
two men on
Go ahead.
this panel to, listen to what I'm saying, and let's go into the patient discussion.
Okay.
So, this is a 50-year-old lady. She's pre or perimenopausal, and she presents with a breast mass that is biopsied. It's turned out to be a hormone receptor positive, HER2 negative early stage breast cancer, 4 centimeter tumor, grade 3, node negative. Oncotype DX is actually not available for this patient. Ki-67 is 40%. Stephen, would you do Oncotype in Canada for this patient? Would it
I
be
would.
standard of care to do it?
She would be eligible T2 and 0 grade 3. We know maybe about 20% of them come back with the lowest oncotype that you could avoid
Yes.
it. So if I had access, which I do, I would do it. If I did not have access, let's say I couldn't get it, I would give her chemo.
And how often are you using the RS Clin score? Do
Very
you have
commonly.
access to it?
Yes, we do. That's I do use it as much for prognosis. So if she kind of comes out with a score of like 21, I think it does give you more granularity in terms of what the absolute benefit is.
Because what makes me uncomfortable about her tumors is still grade 3. I don't
Yeah.
really look at the Ki-67 because I find that, it's just not standardized against or across different pathologists. So Dalia, what would you do with this patient? Would you give this patient chemotherapy?
Yeah, I think she is premenopausal, 50 years old, considered to be premenopausal, as you mentioned. Her Ki-67 is 40% grade 3. We don't have Oncotype DX for her. I will consider giving adjuvant chemotherapy 100%.
Dr. Bassel, would you give her chemotherapy if you didn't have the oncotype, or would you insist on oncotype?
Yeah, I believe most likely if I don't have it, I will err toward giving her like a TC 4 cycles or so. But yeah, I would prefer to have some type of genomic profiling.
So, Dr. Bassel, while I have you, which endocrine therapy partner will you give this patient?
Being a premenopausal or a perimenopausal, I'm favor always of giving ovarian function suppression for those patients being high risk. So I will give her as much as possible, the benefit of the doubt. Once I decided or I completed her chemotherapy, most likely this patient will be getting an ovarian function suppression plus aromatase inhibitor, and I will consider the ribociclib in her case for 3 years, being a grade 3 disease.
Why would you not give it to her straight up?
No, I would give it. I will recommend giving her adjuvant ribociclib for 3 years, being a grade 3 T2 disease.
So Maroun, if I were to tell you that this patient was started on ovarian function suppression plus an AI and she had the crappiest tolerance ever, and she comes to you and she says, look, I cannot tolerate an AI, and you shift her over to tamoxifen and she does very, very well, how are you going to manage her CDK4/6 inhibitor?
Yeah, I mean, you're talking about prolonged QT and ribociclib and tamoxifen.
Yes.
I think it's a minor problem. I think as long as you monitor them, I don't think I would deny her ribociclib for 3, 4, 5% maybe interaction with tamoxifen in regards to the QT. So I would just monitor her more closely with ECGs and give her ribo, continue on the ribo.
So, Dr. Hassan, I know you want to say something. What comment do you want
Well,
to give?
I was
I
gonna
can
say,
feel it coming out of you now.
I was going to say for the future, this is a perfect patient for giredestrant. I know we don't have it, but this is where giredestrant supposedly is better tolerated than AIs. But
So
anyway, we don't have it. But I
Dr.
agree with
Hassan is
Maroun. You can follow.
wait, Dr. Hassan. I want to ask Stephen about this point that you've brought up,
Okay.
which is on the use of an
Giredestrant.
oral SERD. We all believe that it's going to get approved by the FDA very soon. But Stephen, what are your thoughts on the lidERA study? Do you think that there is a subgroup of patients where perhaps you can give an oral SERD and get away with not giving a CDK4/6 inhibitor?
I think there is a subgroup of patients where the added efficacy from an oral SERD like giredestrant improves the prognosis, where the added benefit from a CDK4 on top of that is probably modest. So so I think there are some patients that perhaps it would be an alternative to, because the absolute difference at the end of the day could be only several percentage points and might not be worth it for that patient.
So having seen the results of, I know this, I'm going into the metastatic setting now, but at ASCO, we did see the results of the Persevera study, which showed us that an AI versus an oral SERD was exactly the same. There was no difference between the two groups. Are you expecting in the adjuvant setting, when you give a CDK4/6 inhibitor with an AI and a CDK4/6 inhibitor with an oral SERD, that we're going to see the same, or are we going to see differences in outcome? What's your expectation here?
Uh, it's really fascinating because I think the thing about the Ladera study, it's the first one to report out, and it's great for patients that there seems to be a benefit. Well, there is a benefit. I wonder if part of the benefit is just better tolerance. People are discontinuing less Ladera than not. I think it would be great to see the other adjuvant CDK4/6 inhibitor, the adjuvant SERDs read out before we kind of all jump on that SERDs are better than not. Regardless, it's better for patients, but I think in part of it is due to tolerance. I think in the metastatic setting, it's a different story. Patients don't discontinue their AI like they do in the adjuvant setting. So I think it might be slightly different in the adjuvant than metastatic.
So if you look at the NATALEE trial, this patient actually fits the criteria for NATALEE. It's a node-negative patient. She has grade 3 disease. Her Ki-67 is high. Obviously, an oncotype is not being done. This was the group of patients that was not enrolled in Monarch E. Dalia, would it be unreasonable to give a BEMA in a patient like this, or would you stay away from it and only give ribociclib?
I think, as you mentioned, the patient is not fitting the monarchy criteria. She's T2, grade 3, N0, so she's not fitting it. So I will stick to the NATALEE criteria.
So Stephen, if you look at the ASCO update guidelines that actually incorporated the use of adjuvant CDK4/6, both in node negative and node positive, they make a statement there that states that they don't actually believe that all node negative patients that are T2 and above actually require adjuvant CDK4/6, even if they fit this criteria, but we just simply don't know who benefits and who doesn't. So are you in with those thoughts that perhaps not everyone that fits this criteria actually requires adjuvant CDK4/6?
Well, I mean, the control arm on the no negatives had a relapse rate of 15%. So that means 85% did not relapse when they were on their endocrine therapy without the CDK4. So sure, there's a lot of patients that don't benefit. The problem, as you said, is we just can't figure out who they are. Maybe if you can plug into like RS Clin might help you. For instance, if you have like a grade 2, very low, for whatever reason, Ki-67 was 20, but you did an oncotype, it was like 6, and then the tumor size was like 2.2 centimeters, 0.5 lymph nodes, and the risk of a distance recurrence was less than 5%, then I might not offer it to them because I have more prognostic information and the absolute benefit will be less than 2% there.
So let me ask Dr. Bassel this question. Say suppose this patient's tumor was sent for oncotype and the oncotype came back with a recurrence score of 19. And if you go back to the characteristics of this patient, she has a grade 3 disease, Ki-67 is 40%, so she still fits NATALEE. So at this point, would you use an adjuvant CDK4/6?
Yeah, I mean, it's great that they have included more criterias for selection of patients that are high or risk, to benefit from the CDK4/6. But clearly, we also know that by the grading and by the Ki-67, we also have enough data to show that they would benefit. And if anything, genomic profiling, I feel it's better to explain. Prognostically, it is worse and better to explain the decision about the adjuvant chemotherapy. But even if she has a low or moderate intermediate oncotype DX, this patient actually will make me feel we need to push more toward the adjuvant treatment. And that's a good news for her, because that means that I could maybe skip the chemotherapy part.
So I'm just going to push on because we're pressed for time. But I just wanted to look at the data of Natalie in patients with node-negative disease. You can see that at 4 years in exploratory analysis, you can see 5.1% absolute benefit in terms of using adjuvant CDK4/6. And when you see the 5-year pre-specified, you can see that it is 5.7%. Now, Stephen, when I looked at the data that was presented last year at ESMO, for me, I felt that the benefit of using adjuvant CDK4/6 was actually higher in your node-negative cohort than in that node-positive cohort. Is this because that node-negative cohort is a cleaner, truly high risk, that they actually mirror your very bad prognostic group of patients compared to the bigger cohort of node-positive patients that included N1 low risk as well as N1 high risk?
You're absolutely right. Yeah, it was a cleaner, excluded grade ones. They had to be a certain tumor size versus your N1 could be any grade. So you're absolutely right. It's more homogeneous in that regard.
Right.
Okay.
So Shaheenah, a 4 centimeter
Yes.
tumor, grade 3, 40% Ki67 is worse than somebody with one positive node and a grade 1 or 2 with a Ki67 of 10%. So exactly the same. So that's why this group is actually at high risk of recurrence, just as a 1 to 2 or 1 to 3 lymph node positive.
Okay. What are your thoughts here, Maroun?
Or
Maroun?
yes, I'm here.
I wanted to know your thoughts in the node-negative cohort of patients in terms of using adjuvant CDK4/6.
I mean, if they fit the criteria of even if node negative grade 3 oncotype DX, I believe in oncotype DX more than the Ki67. I feel like if I have a Ki67 of 40% and an oncotype DX of 19, like you mentioned, I'll go with the oncotype DX.
Actually, when I got the results back from my patient with an oncotype of a recurrence score of 19 and a KIC7 of 40% with a grade 3 tumor, I went back to my pathologist and I said, look at it again. I don't believe that this patient has a KI67 of 40%. All right, let's jump on to the second case. This is a 55-year-old lady, postmenopausal, married with 5 children. She presents with a 4-centimeter tumor. It's grade 2, 2 clinically positive lymph nodes, so it's an N1 disease, stage 2B. Ki67 is 35% and the recurrence score is 27. So Maroun, while I have you on the online, let me pick on you. What would be the treatment option for your patient? Chemo followed by endocrine therapy alone, or would you add a CDK4/6 inhibitor? And if so, which one?
Yes, so she has 2 positive lymph nodes. She has an oncotype DX more than 26. I think she qualifies for chemotherapy, followed by endocrine therapy and ribociclib. Number 3.
Number 3. Stephen, we have the second cohort that was included in
Monarch E.
which actually looked at those patients with a KIC7 of 20%. Now, it's never been read out separately, but it's always been part of the intent to treat analysis. So in a patient with a KI67 of 35%, because I can see that that's the only criteria that would make her fit Monarch E, would you have a bias between ribo and abema in this particular patient? And if so, why?
So they're both available in Canada. So cohort 2 for Abema, and this fits Natalie. I don't think I can say one is better than the other. So to be honest, I know that they're different in duration and toxicity, and I would offer both and have a discussion, to be honest, for both.
Dalia, what are your thoughts here?
Yeah, I think as mentioned by Stephen, both options are there. I will consider giving chemotherapy because of the oncotype, but both options are there. I will put the toxicity to the patient, will tell her about it, the difference between 2 options, and I will let her choose between them.
And Hassan, what are your thoughts here? Because
Yeah,
you have
I
an
agree.
opinion.
I agree. I think you can, it's a toss up between ribo and abema. Maybe the side effect may win here. I think this is a small, portion of the study for Monarch E, but it is there. I'm too naive to think that it will not work here, but certainly I think ABEMA benefit is there. Now, whether the survival benefit that we saw, 1.6% from the Monarch E, would push you to use that, I'm not sure. I think if you look at all other IDFS, etc., they are really trending the same, almost carbon copy of each other. So again, it will be more about toxicity decision.
I mean, from my opinion, in practical, daily practice, I think ribo is in general better tolerated than ABEMA.
Yes, no
Unless you
question.
dose reduce. I mean, so that's clear. I mean, so ribo I think is better tolerated unless you go down to 100 milligram or you go down to 50 milligram or whatever.
See, Stephen, one of the questions that's repeatedly coming up, at least in the community, is the duration of CDK4/6. If you had a patient that has, say, and we see this quite a bit in our part of the world, a 5 centimeter tumor, 9 lymph nodes that are positive, so a really, really bad tumor for a patient, where we know that the long-term risk of recurrence is also there, including the short-term risk. Do you believe that giving 3 years may be better than giving 2 years in such a patient?
Great hypothesis. Don't have the answer. We need longer follow-up on Natalie. What we do for monarchy is after 5 years, the curves stay apart, but they don't expand even more. So I'm not convinced that we have a effect on late recurrence with the BEMA. Whether one more year of ribo will make a difference, honestly, we'll have to see. There might be 6-year data coming out from ESMO for Natalie. We'll see if that shows something or not, but I think it's really unclear at this point.
And in these patients, would you give extended adjuvant endocrine therapy?
Absolutely, yes, for the ones you described. Yeah.
All right, so let's go to our last case. We have 4 minutes. This is a 50-year-old lady. She has a hormone receptor positive, HER2 negative tumor. It's PT2, 4 centimeters. Now, this is truly overlapping population of Monarch E and Natalie, where this patient has N2 disease, grade 3. The Ki-67 is 17%. I suspect this patient has an invasive lobular. That's why we see so many lymph nodes. So Maroun, what would you choose for this patient? It's N2 plus. So this is a patient with a huge tumor burden.
You're talking about CDK4/6, right?
CDK4/6.
Yeah, I think, I mean, more than 4 positive lymph nodes, I think there's more data about sticking with abemaciclib, definitely. And but really, there comes an issue about dose reduction of abemaciclib, and I know there's plenty of data about okay, if you dose reduce, you don't lose efficacy, but I mean, this patient I would go with abema.
With ABEMA. Is it the overall survival data that we've seen for ABEMA, or is it just that it's a cleaner cohort with a a big group of patients with this type of disease? I think almost 60% of patients enrolled in Monarch E had N2
Both.
disease. So is that the reason why?
Both, I think, the number of the lymph nodes and the overall survival. So
Stephen, to you, I'm going to ask 2 questions before we sign off, and then I'll ask the same question to the rest of the panelists. The overall survival advantage that we saw in Monarch E was great. It was about 1.8%, but I'm seeing the same trend that's emerging now with Natalie. So I don't think that the OS is going to dissuade me from using one study versus the other in terms of the type of CDK4/6. But the reality is Monarch E was a cleaner cohort of patients with N2 disease, very, very high risk, versus Natalie that only included 20% of patients that had N2 disease. Would that drive your decision-making process in terms of what you're going to use for an N2 patient?
It just makes a little bit of an easier communication with your patient that they really fit the monarchy high-risk population. You can quote them the 6-7% difference in disease-free survival and then state overall survival. So I do tend to prefer ABEMA upfront for my N2 disease. The advantage of ribo is if they don't tolerate the ABEMA, I can switch them over to ribo.
And Bassel, yourself, what would you give this patient? ABEMA or ribo?
I do agree with the same process, thinking process, is that I would, those patients, probably offer them abemaciclib I do the tailored dose
From the
increase,
trade
which is
study.
yes, a trade study. That's my approach with the 50, 100, 150. I think they tolerate better. I have much better success for the 150 doing it this way rather than the opposite. But if patient
Okay.
cannot tolerate, then I can go down to 100 and I have the ribociclib as a backup plan.
Dalia, Abima, or Ribo? Because we are at the top of the hour.
I don't think we need to do a separate study to prove that ribo will be effective in N2 high risk, high
So
burden.
what would you use, Dalia?
Both of them are option for me for the
Okay.
overlapping. Yeah.
And Hassan, I just need you to tell me, Ribo
Sure.
or Abima?
I'm going to use, I think it's an easier communication. If you choose abemaciclib than ribociclib, you have to defend more. And I use what Bassel has mentioned. I use a low dose and go up.
And escalate. Well, thank
Yes.
you all. We have reached the
Thank
top
you.
of our hour. This has been an excellent discussion. Thank you, Stephen, for coming on board all the way from Canada to give us the updates as well. I hope to see you all at the next edition of the EIOC Journal Club. Thank you.
Thank you. Thank you. Good night.
Bye-bye.
Thank
Good
you.
night.
Have
Bye.
a good one.
Good
Bye
night.
bye.
And good morning for Dr. Chia.
Yeah.